Yes, my name is Jeanette Fernandez. I'm a COMT, been working with Virginia Eye Consultants close to 20 years. And I started calculating lenses for our surgeons probably starting in 2004. And yeah, I do that every day. I still see patients every now and then, but yeah, my mostly my full-time job is calculating all the lenses for the doctors.
Right. And it's really incredible. I mean, Jeanette does, it's so important that we're always being updated in terms of our own education process with all the modern formulas. And it's amazing actually when we go to the meetings like ASCRS, she'll walk up right up and ask a question to Dr. Hill, when there is time for question and answers, because, with all of the different surgeons, we have different locations of wounds and how does glaucoma surgery affect things and our wound placement. And the nuances and that having a Jeanette who really is so talented and really an expert at lens calculations at this point. So Jeanette, busy. And I mean, we started using Veracity pretty early on, maybe three years ago when I
I
really
think
got on
so.
board.
hmm
Yeah. Can you walk us through, the arc of your journey with Veracity and how many surgeons are currently utilizing it and what you've seen as being like the main benefits of it for you?
So we have 4 surgeons total in the practice using Veracity. Dr. Yeu is the one who uses it the most. It's been a lifesaver. Before Veracity, I was using the holiday program and also going to the online calculators, entering all the data like manually. Um, I would spend about 15, probably even close to 20 minutes per patient. But now using Veracity, it's really cut down my time for each patient to like almost like half,
Oh,
like
that's
10.
incredible.
Yes, yes.
And even with that, that's really just kind of checking and double checking, just
hmm
that everything is in place in terms of what type of lens that the patient may want, and just making
Yes,
sure that all that default is being set up. So
yes.
I use it, we all use it differently as surgeons within the practice itself. During the day, as I'm seeing my cataract surgery evaluations, I know there are doctors who are taking the Veracity right into the room and kind of creating everything right there on the spot. For myself, within the EMR system, I am picking the plan, the goals. I actually, before I decide what kind of lens implant we're utilizing, all the preoperative diagnostics, which is uploaded into NextGen, I actually like to look at the quality of the topographies just to make sure and make sure that I'm liking what I'm seeing between the values of our Lenstar, our Cassini, the Pentacam, the OPD, the Atlas, especially for our post-refractive patients. What is beautiful is that within the Veracity system itself, as others have mentioned, when Jeanette goes into it, the actual values, at least the quantitative values, are right there, which then allows us to say, okay, if I know that I didn't like the Cassini, I would click that off as we're utilizing the very integrated and such. So to me, that has been the big game changer, the fact that obviously it is automatically uploaded. And my favorite part is actually looking at the cataract surgery plan, which I can't wait to kind of show you as Jeanette goes through the process of calculating this patient that we have selected, who one eye I know will be getting a toric, the other eye is just on the cusp of needing a toric because of the level of withdrawal anterior stigmatism. So this will be a fun calculation. We haven't actually gone through the whole thing yet, but then the actual final plan is wonderful to see, just very specifically because it allows me to take that, and Jeanette has it printed for me and I can look at it right in the operating room, which is really fantastic.
hmm
So this is a patient who is 64 years young. And as you can see here on the amount of astigmatism, the Lenstar, the actual K values does show a delta of 1.88 diopters at 76 degrees on the right. And on the left eye, it's less, still with the rule, but about 1.21 diopters.
Once I pull up all the scans, lens star, and also I'm in the patient's chart also, so I'm looking at the lens star, and also, so I'm kind of just checking it against the veracity too, just make sure like everything was brought over correctly.
And that's for real exactness, because that's just being uploaded into the system.
Yes, and then we're going to look at the Cassini.
Yep.
And all right, so 4083, 4299 at 77, and then our OPD. There's the OPD, 4116, 4338 at 82. Okay, looks correct.
Yeah, and look at the quality of those Myers are really excellent. And so then what I love is that I can just look right here at the average K values and see that truly, I mean, they're no more than about 0.3 diopters apart, going straight down the line of the keratometry values. The SIL values are all reading between 187 and no higher than 2.22. So again, not a huge major difference, but definitely demonstrating that between the average K values and the SIL values, here, I love that this, and using the Barrett integrated formula would be a really solid way to go, because as Barrett has shown, having the integrated formula, especially with multiple devices, it can give you more accurate outcomes to your prediction error for astigmatism management.
And also, I also like to look at the biometry also from the lens star, make sure that's correct. 2617, ACD is 356, lens thickness 447, and then.
Can you click the Barrett integrated K number, the
Yes.
line? Yes, perfect. Just so that, and you can see there, so like when you look at the top, so when you click the Barrett integrated K, it showed you what the anterior K value would be, which is the 2.13 at 78, versus, let's say can you unclick the Cassini? Oh, let's unclick the Cassini for me. And you see how it automatically changes it to 2.04, like just like that with a click of a button, which is so impressive. And what I love seeing here is look at the original refraction, which is right there, to demonstrate like this is not completely incompatible with what you're seeing in the patient's refraction, So if you could click the Cassini back on, it was just to demonstrate, like to have that. Now, is there ever an upload error in the way the values actually are uploaded from the devices into the Veracity software? Have you ever caught an error in that way in the thousands of lenses that you've calculated through Veracity?
No, there has been no issues with bringing it over. Sometimes I think there is, because I'm looking at like different dates of like when a lens star was taken, and I'm thinking, oh, there's an error there, but no, it's just a different date.
And that makes so much sense, because there are times where, for example, I'll have fixed anterior basement membrane dystrophy. And so after that superficial keratectomy, and they've come in 6 weeks later for repeats, that second lens star may not have been uploaded, which you can adjust to make sure that the proper uploads are. And so that exercise makes so much sense as to what you're doing. So let's say that we want to go through and pick a lens, and this person was going to be like eye hands toric or something like that, and we're going to go for distance.
So right now I have all our IOL types. So if I just want to focus on just toric, I'll hit that all the way to that left. Cool. So it'll just bring up all the toric models that we have. So we want to use the iHance toric, and then our target range is.
Oh, totally pulls it up automatically.
Yes, let's just confirm
Oh, I love that.
from the plan.
Right.
Because I know sometimes you like to go plano or plano to
Yep.
plus a quarter or yeah.
Yes,
So
you're right. Because
right
like when I
eye
do
is yep.
synergy,
Mm-hmm.
yep.
So minus a quarter to minus a half. So we'll keep it up about minus a quarter there.
Oh, I love that you can just kind of look at it side to side and just to
Mm-hmm.
confirm, because we do have that separate sheet where I do write that goal very
Mm-hmm.
specifically just to
Yeah.
ensure.
I'm choosing our go-to is the Bear Universal 2. So if I want to look at the up or down, I'll just click what the 16.5 will give us, which is a little bit too much. That's 0.81. So let's see what 15.5 is. 15.5 is minus 0.13. So not in the range that the doctor wants. So let's go back to 16, which is the minus 0.47. It's perfectly in that range that the doctor wants. And I believe this is the non-dominant also.
Oh, I love that. Right. So it pulled in that it was the non-dominant dye. And it also
Yeah.
pulled in that there was no prior refractive surgery or anything like that.
Okay. Do you want to see what the DIU 150 would be? Because yeah, because right now it's the residual is 0.12 at 76, which is I
See, and
think
that's
looks
perfect for me.
good. Yeah.
Yeah, that's like so solid
Um, so let's look what the 150 would be 0.62.
at 76,
Now
right?
that's mm-hmm.
And then show the other one the other way, because some people would flip. And you know, my go-to is always going to be leaving a little bit of residual with the rule.
Yes.
Yep.
So that's going to go against the rule.
Right. So you're just kind of
0.37.
confirming. And look at that, that it shows
Mm-hmm.
you in red that it flips the meridian when you do it that way,
Yes.
which I love that.
Right there.
Yep.
Mm-hmm.
So I agree with that 225. And that's
Mm-hmm.
my favorite part, is that you get all this information and it pops right up on the plan when you do
Mm-hmm.
have this final plan.
Yeah. So let me go ahead and approve. And it just brings up, different warnings.
Right. But this is what's so great. See, so it
Mhm.
shows you that the axial length's long, as we talked about, that the the corneal powers may differ by more than 0.35 diopters for this eye. And it was like one, it was barely, it was very similar. And the K meridians differ by more than 4 degrees for this eye. And that's because of the defaults that I had. And it was actually 5 degrees. It was like 76 to 82 or something like that, so 6 degrees, but
Mhm.
still very, very close.
And
But
then so you just hit the acknowledge and alerts and approve. And I'll show you how the printout looks.
this is
So I do.
my favorite part. Can you enlarge this for us to look at?
Yes.
And this is what yep, take with me to the operating room. And I have that information, and I love that predicted outcome. And I love seeing what the residual refractive error is going
Mhm.
to be. It tells me that I used, the Barrett integrated. It also shows me what other backup
Right there.
lenses I could be using. And then lastly, the post-op refraction will, when it's populated for the second eye, it'll come up. So then I could know what that post-op refraction looks like, so that I know for my second eye what my thoughts are if I wanted to fudge it one way or the other. How would you say that your overall impression has been?
It's very efficient and it's really a lifesaver because it cuts down so much manpower. So yes, it's very quick and yep, very accurate. And the results are wonderful.
Oh yeah, I mean, it really has been, and we're being able to refine ourselves, right, on the post-operative
Mhm.
side so quickly with those analytics has been really, really nice. And it can be with lens type or different formulas, et cetera, et cetera, and
Mhm.
seeing those graphical images. Well, thank you so much.